Thank you very much for that kind introduction. So we'll start with a question right at the start. How many people think it is Parkinson's disease? Hands. And how many people think it's Parkinson disease? Yeah, so it is actually Parkinson disease, not Parkinson's disease, because James Parkinson did not actually have Parkinson's. So when we ascribe, so it's Huntington disease, not Huntington's disease. Although we use that interchangeably, the actual correct usage of the word is in fact without the apostrophe S, because one would think that the ownership of the disease, i.e. the label, depends on actually having the illness, and he did not have the illness, hence we term it Parkinson's disease. So it's a great privilege for me to talk to an audience where we are communicating to you something about this very important illness, as well as telling you what kind of research we do at Western University here in Parkinson's disease. So what I'm going to cover today, and then please feel free to ask questions in the middle if you'd like, but at the end, a brief overview of the anatomy, physiology, the cardinal symptoms, and really some important issues in terms of, are you at risk for getting Parkinson's disease? As I was just saying, we were at the Huntington Society meeting in Toronto, where there was the second of the talks, and at that particular meeting, we talked about a disease, Huntington disease, where you have an inherited gene where the penetrance and occurrence of disease is 100%. Well, Parkinson's disease is not like that, and it's much more difficult to tell people what it is about Parkinson's disease that makes somebody more vulnerable or less, and we'll talk a little bit about that. We're going to talk about what I call the treatment home run, and the reason I put it that way is because people always want to know, patients, including some of my patients in this room and others, what is it that is different, what is new about treatment in Parkinson's disease, and I call the treatment home run as a problem in terms of answering that question easily. We'll talk about that a little bit. And then again, what we're doing in London. I know that the topic was advertised as talking about virtual reality, but we want to talk about real reality first before we get to the virtual part at the end. Okay, so here's the simplistic diagram of the brain. We start with a little bit of anatomy, very simple, and the reason to talk about this is because Parkinson's disease, Huntington disease, these other conditions which I see in terms of movement disorders is actually a set of conditions that are conditions that have pathophysiology or pathology in the basal ganglia. The basal ganglia are actually groups of nuclei, which are clumps of neurons in the brain that are inside deep parts of the brain. So these structures that we'll point out here, the thalamus, the caudate nucleus, the putamen, the globus pallidus, the substantia nigra, which is here, subthalamic nucleus, all of these structures make up a group of nuclei meaning a conglomeration of neurons in the brain that are called the basal ganglia. They're deep inside, and many other animals possess the basal ganglia as compared to the frontal neocortex, which we have much more of. So Parkinson's disease is a disorder of the basal ganglia. Huntington disease is similar. And this is a pictorial view of how those basal ganglia sit deep inside. They're connected in a very complicated way, which we'll talk about very briefly in a couple of minutes. So this is a section through the brain of the basal ganglia. The same thing that you saw here in the cartoon actually is real. And the reason that this is important is because when we do deep brain surgery, for example, the reason I wanted to show you this, we actually go deep down, where's my mouse? Down here. Okay, so you can see how high the surface of the brain is, way up here. So we go about 6-7 inches deep into the brain to be able to target this structure, this little guy down here. This is the subthalamic nucleus. So those of you who have heard of stimulation in the brain, deep brain stimulation, that's the structure that the surgeon targets. So look at the size of the brain and look at where we got to go. Right? And so this is technically an extremely challenging procedure which the surgeons make look very easy, but it isn't, and hence doing DBS in patients, which we'll talk about again very briefly, that's why I orient you to the anatomy, is not something that's child's play. In fact, it's much harder than surface surgery. So that's the anatomy. This is again the same set of structures, the putamen, the caudate, mammillary body, and then below here will be the the substantia nigra, thalamus, globus pallidus. So we do pallidotomy, subthalamotomy, and subthalamic nucleus stimulation over there. This is the temporal lobe, hippocampus. That's the orientation of the brain as it sits. Okay, so these are deep nuclei. And then to again pictorially show the connectivity of these set of structures, we've drawn that diagram here, which is used for very simplistic teaching of what it is that the basal ganglia do and how they're connected. So here's the cortex, which is the big, large structure, and in fact everything from the cortex projects down to that set of nuclei, the caudate and putamen, together called the striatum. Okay? Then you've got the pallidum, the subthalamic nucleus, the names that I just gave you, another part of the pallidum, thalamus, and cortex. So the basal ganglia deep inside the brain form this, again this is very simplistic, but form this structure which is connected like this, like a loop. So there are loops that take information from the cortex, feed it down through the nuclei of the basal ganglia, and they project back to the cortex. So one of the things that people conjecture, including scientists like me who work in the lab, that the basal ganglia do, is that the basal ganglia act like a filter to the cortex. The cortex gets all of this information from in the environment and surrounding, takes it into the brain, and then says, what do I do next with it? And it gives all that information down through this set of filters, the striatum, pallidum. You can almost imagine these are layers that filter out the information. All the junk is filtered out, and then a little nugget of that's what you need to know is put back to the cortex. And the cortex learns that. And as children learn this, they have better and better filters. We get together in terms of these nuggets and put them all in the cortex so we can do tasks like this kind of a thing very easily. Right? So the basal ganglia are involved in teaching the cortex motor actions. And in fact, the feeling is that the substantia nigra, which has this chemical dopamine, reinforces those actions that give us positive reward and doesn't reinforce those that give us negative reward. So dopamine is felt to be involved in reward-mediated things, which is one of the problems that we face in patients with Parkinson's disease sometimes, where there's need for excessive reward. So this impulse control disorder that has been described in some patients with Parkinson's disease, where you want more and more medications, can't get enough, like an addictive behavior. So in fact, the science of addiction is also based on this dopamine phenomena. Very simplistic. Another example is schizophrenia. The feeling in schizophrenia is that this dopamine system is very high as compared to Parkinson's disease, where the dopamine system is very low. Now, the reason that the dopamine is very low in patients with Parkinson's disease is not because the actual chemical drops, it's because the neurons that are in this substantia nigra, which project to this striatum and accentuate that reward signal, the neurons in that region actually die. And when the neurons die, then there is effectively less dopamine. The one last thing I'll say about this diagram is that you'll see that there are two pathways. There's this pathway that goes this way and another pathway. Again, it's very simplistic, but we call this the direct pathway, and this the indirect set of filters. So there's a direct set of filters, and then there's an indirect set of filters. And the feeling is that this action control system is balanced by the direct and indirect pathway. Well, if you have an imbalance of that chemical dopamine, and we won't go into the details of the diagram, but you can see that the arrows change thickness. This is supposed to be equal, this becomes thin, that becomes thick, that produces a series of imbalances in the system like this, so that finally, by the time you get the final output, all the arrows need to be of the same thickness. You lose that signal from the thalamus in that loop back to the cortex. So the motor control theory, Nicole told you that I have an interest in motor control. Motor control theory says that that output going to the cortex is reduced and everything then slows down. Again, it's obviously not as simple as that, but that is how we in fact envision this loop of basal ganglia. So you've seen the anatomy and you've seen the connectivity and what dopamine and these chemicals do. So what is Parkinson's disease? I put that in specifically because, as you know, people use that interchangeably, and hence this is what you will see in the literature. So Parkinson's disease / Parkinson's disease is actually the second most common neurodegenerative disorder. So as our population is living longer, I wouldn't necessarily say that the incidence of Parkinson's disease is actually increasing, but it's just that people are living longer and longer. And some would say that if you live long enough, you'll probably get every neurodegenerative disease that there may be. In some it might be 150 years, in others it might be 65 years, etc. So there was a time when people lived at the age of 50 and didn't live beyond, and hence you did not have the same number of patients with Parkinson's disease. Today, the prevalence of Parkinson's disease is about 160 to 200 per 100,000. So if London is 500,000, we have about 1,000 patients with Parkinson's disease in just the vicinity of London area. In our clinic, we have about 3,500 patients with Parkinson's disease that I look after because we see patients all the way from Sault Ste. Marie and Thunder Bay and Timmins and other places, etc., and Windsor to Niagara Falls. So we have a fairly large catchment area. We even see patients sometimes from Halifax and Winnipeg. But we have a huge number of patients with this illness. The incidence, the number of new cases, is about 15 to 20 per 100,000. The mean age in our clinic is about 55 years, but most people quote 60, 65, but there are lots of young people. We diagnosed a 44-year-old from Sault Ste. Marie just 2 days ago in our clinic, and it's not uncommon for us to see somebody like that. There is a male predominance after 80, but before that, in the 60s and 70s, the male-female curves in terms of incidence and prevalence are fairly equal. And then after 80, it seems that there are definitely more men with Parkinson's disease than women. Symptoms usually begin in the upper extremity, but that's not a given, so we routinely see patients referred for something random because it's in the leg, and it actually is classic Parkinson's tremor in the leg. So about 30% of the time, tremor can begin in the legs. Okay? So some other important statistics. Now, I talked about incidence and prevalence, but the lifetime risk of getting Parkinson's disease is 1 in 40. The risk, which means what is the risk of us getting hit by a car if we were to step outside? It's not the number of people that actually get hit by a car, but it's the risk. So it's a fairly high risk. It's 1 in 40, which is about 2%, right? 2% risk of getting Parkinson's disease, about the same as actually having a seizure. Okay, so about 2% chance of any one of us having a solitary single seizure. Okay. The risk in the first degree relatives is approximately 2.5 times higher. That means if you have a father, mother, immediate blood relative, brother, etc., that has Parkinson's disease, then your risk of getting is slightly higher, 2.5 times, so 2.5 in 40 risk. Okay? And the risk increases at the age of 80 without family history is about 1 to 3. If there's a parent or sibling with Parkinson's disease, 5 to 6. And then if you have a parent and a sibling with Parkinson's disease, there is a higher and higher risk. Now, this doesn't tell you that the disease is genetic, because it could very well be that these people have been exposed to the same kinds of things, that they've been living in the same environment. And hence, it is not a harbinger of genetics of Parkinson's disease only. Okay? So that's some of the epidemiology statistics, the anatomy of Parkinson's disease. Parkinson's disease was actually labeled Lewy body disease. And I wanted to specifically talk about Lewy for 2 seconds, 2 minutes, half a minute, because there's a condition called Lewy body dementia. Okay? And even in the medical community, there's a huge degree of confusion, and some of you might have heard this. I've got a family member with Lewy body dementia, or I've got somebody with Parkinson's disease and Lewy body dementia. Well, it doesn't work like this. Lewy body disease is a specific disease, even though it's spelled the same way, and it is not Parkinson's disease. So Parkinson's disease is very specific in terms of how it presents. Lewy body dementia is not synonymous with Parkinson's disease, even though the pathology of Parkinson's disease is the presence of these pink things here. So this is actually a brain cell, a neuron, and you can see this inclusion body with that pink internal component, and then the halo around it described by Fred Lewy and called Levy body or Lewy body. And this became the pathogenetic hallmark of cells in the substantia nigra that I showed you, where these Lewy bodies accumulate. In Lewy body dementia or Lewy body disease, these Lewy bodies accumulate also in the cortex, the one I showed you at the start in that picture, not just in the substantia nigra, and it's diffuse Lewy bodies in the cortex, different disease than typical Parkinson disease. Okay, so that's one of the reasons to show you. But the pathology of Parkinson's disease is very well described in terms of what it looks like. This is a section through the brain stem, which is just above where, or just below where I showed you in that cartoon, the brain stem attaches. So brain stem, and these black pigment-containing cells are the cells that are substantia nigra cells. So these are nigral neurons which contain not dopamine, which is not black, it's actually melanin. Same thing in your skin, same melanin. And believe it or not, brain actually comes from skin, or skin comes from brain, i.e. they both are of the same embryonic origin, which is ectodermal. So melanin pigment, same melanin pigment in here. This is a reactivity of oxidation that occurs inside the cells. This is a Parkinson brain. You can see that there are no black containing cells left. There's a little hint of something here. So the cells are all gone, and you can see that in this slide above, you see these many neurons. These are all black pigment in the normal brain, and they're all gone in this particular. And those remaining neurons that you see scattered around have that Lewy body or Levy body. So this is the summary of pathology from gross anatomy to slice to actual histopathology of Parkinson disease. So that's what it looks like. And based on that, there are a whole host of, and we don't need to go through this because there will be a quiz at the end, right? So yeah. So in terms of what it is that causes this to happen, this being loss of cells that are there in that substantia nigra, and accumulation of that Levy body, and then of course getting Parkinson's disease, and we really don't know. And people have talked, and we'll go through that in a little bit in terms of what those factors might be. And people have talked about inflammation, toxicity, free radicals. So there's lots of these scavengers, so eating organic food that takes away oxygen radicals and things like that. So there's a whole host of these kinds of laboratory conditions that kill cells. So if you take a bunch of cells in a dish and you subject them to these kinds of toxins, yes, you will kill them. Problem is, to be able to demonstrate that from in vitro in a dish to in vivo in the brain has been a huge challenge. We've not been able to find anything in Parkinson's disease literature that has been conclusive saying that, yeah, you'd, like cholera, for example, or plague, where you get infected by a particular bacteria or a virus or whatever, and you are going to get this particular disease. That kind of connectivity is not there. So there's a lot of susceptibility, and we'll talk about that. So currently, the hypothesis is mixed, and we'll get to that in a minute. So here are a bunch of environmental toxins that are available that can kill these neurons. MPTP, this one called methylphenyl tetrahydropyridine, and you'll be asked to spell it backwards at the end. This is a compound that actually drug addicts in California manufactured in their ingenuity, thankfully to us, in their basement. And in the process of making Demerol, meperidine, they made this compound, which actually was it made an analog of it called MPP+, which was neurotoxic. And as luck would happen, helpful for us who do models of animal models of Parkinson's disease, these patients ended up developing acute Parkinsonism. And long story short, found out that this is a neurotoxin that can be used in animals, rodents, monkeys, etc., to make an acute model of Parkinson's disease to study. Now, animals don't get Parkinson's disease. This is an animal model, but it still helps to study, for us to study. And then there are others, things like rotenone, maneb, and paraquat. These names, for those of you who are gardeners and who used to go to gardening centers, would maybe know, because these are all available on the shelf and still are in most places. Now, all of the models with these pesticides, organophosphates, and insecticides have been shown to cause Parkinsonism in animals, but given intraperitoneally into the abdomen, not with ingestion. And then there are links to cigarette smoking that decreases it, and this is real, which doesn't mean that we actually tell people to go and start smoking. But at the same time, it may very well be that those that are smokers have simply got higher number of dopamine-containing cells in their substantia nigra. We don't know that. Most smokers will not voluntarily allow us to take parts of their brain, and hence we really can't determine exactly what it is about smokers that allows this to happen, but it's real. I mean, this is unfortunately real. And this is also not because, as I said earlier, if you die early, then you're not going to get Parkinson's disease. But this is not because cigarette smokers die of lung cancer early, hence they don't get Parkinson's disease. These are surviving patients who don't have lung cancer. So there's something about, so people have tried nicotine patches and things and they don't work. So caffeine also decreases the risk to some extent. heavy manganese exposure and welding may increase. In fact, there have been lawsuits against certain welding companies, and truly if you are exposed to heavy fumes, then you may be at risk. It is possible. And then one of my very good friends, almost actually my mentor, Dr. Ali Rajput, has described things such as rural living, well water drinking, but it's a bit complicated because it's quite possible that if you're drinking well water, you're living in the rural areas, you may be using a lot of pesticides, and maybe you're welding and cigarette smoking is not an issue, etc. So this becomes a complicated set of factors in terms of producing a very definite pathway to asking why somebody got Parkinson's disease, right? So, and then there are some other environmental causes that have been described in the world, right? So we talked about what we could be exposed to, and then there are a bunch of, again, this is just to show you that there are other forms of neurodegenerative disease that occur in terms of consumption of cycad fruits and flying foxes. I'm not sure why anybody would eat flying fox, but there are Indians, Camaro Indians in Guam that actually get this disease called Lytico-Bodig, which looks like Parkinsonism from consumption. There's also Anonacia moricata, which is custard apple consumption. Chickpeas can cause heavy-duty ingestion of chickpeas and cause latherism. So there are these naturally occurring and nutritional things that people do eat that are neurotoxins as well. But most patients with Parkinson's disease are not eating bats or foxes and are not exposed to MPTP, and nor do they have a very obvious history in their family of Parkinson's disease. And this is where we've run into trouble in trying to find an exact road or path to pathogenesis, why those cells die. Initially, when we had the first discovery of genes for Parkinson's, there was a gene for Parkinson's disease called PARK1, this gene called synuclein. This was described by Polymeropoulos in Greek literature family. It was wonderful discovery saying that this is genetics of Parkinson's disease. There's a gene for Parkinson's disease. There's a gene for Huntington disease which had not been discovered, but now there's a gene for Parkinson's disease and we exactly know what it is, and here we go. Unfortunately, what ended up happening is that unlike Huntington disease, where there's only one gene on the fourth chromosome, we now have 17 different genes that have been described for Parkinson's disease, and we really don't know which one of them. In fact, the first one, this one, which is the autosomal dominant form of this protein called synuclein, unfortunately, that actually is a rare form of disease. But still, today we know that about 5, maybe 10% of cases have a reasonably strong family history. Unfortunately, just because you have a family member, or fortunately, whichever way one goes, it doesn't necessarily mean that if you have a family history that you're going to get the same level of disease. We can't say that. Currently, the most popular form of Parkinson's disease inheritance is this thing called PARK8. About 8% of patients with Parkinson's disease have inherited form, and in fact in the Africans that are in a northern part of Africa, so northern African populations seem to have 30% of their patients with Parkinson's disease have a LRRK2 mutation. So there's something intriguing, and in fact we're going to be doing a research project collaborating with a set of families from Toronto with my former supervisor and mentor Tony Lang, hopefully in the next few months, in doing a very special form of imaging, which I'll talk about at the end. So here are all the lists of genes, and it gradually it was very interesting initially, and then gradually became very complicated because you've got so many of them that we can't really isolate a specific one. So LRRK2 is there, glucocerebrosidase, which is this one, which is an inherited disorder of glucose metabolism in the brain, can also do this. So today, what we think, which is not particularly an intelligent thing actually to say, that we all have genes. There's 30,000 genes in our body. So there's a genetic predisposition to getting Parkinson's disease, and then something happens. So if you age normally, and I certainly am not aging on a linear line. I'm doing something a little bit different than that. But most of us would cartoon it out by saying that we age linearly like this till the age of whatever it is. And then what happens in Parkinson's disease is that you have a predisposition, genetic predisposition, so you're already at risk, vulnerable, and if nothing happens, then you might still follow that curve. But then something happens, exposure to something that is otherwise not toxic in the normal scheme of things, but then you get toxicity and gradually you hit that disease threshold somewhere here at the age of 40 or 50, 60, depending on when it happens. So this is currently the double hit theory of, well, it's true for any disorder, right? I mean, I have a predisposition to getting migraine, then I have a glass of red wine or a lot of chocolate and I get my migraine. Well, it's a genetic plus environmental. So it's not a unique discovery, but certainly in Parkinson's disease, this is something that maybe has a little more hold in degeneration than migraine does, okay? So we've talked about the pathology, the anatomy, why it might happen. I'm going to talk a little bit about the cardinal symptoms and treatment, and then we'll go on to some other topics of interest. So the cardinal symptoms of Parkinson's disease is what I learned. So if I were to put, I can't do that on this thing, but if I were to cover the bottom half, when I went through medical school, let alone my fellowship in the early 90s, which now almost is 20 years ago or more, none of those bottom symptoms of fatigue, constipation, hypotension, we knew a little bit about depression, pain, etc. None of those were recognized as Parkinson's disease. We called Parkinson's disease a motor disorder. Why? Link back to what I said the basal ganglia do. They're a motor control group of nuclei. They make us move. They teach us how to move motor things, etc. So we recognize that the cardinal symptoms of Parkinson's disease, and even today, we still recognize the cardinal symptoms of Parkinson's disease as being those that are involved with motion, shaking, stiffness, lack of motion, slowness of movement, falling, all of these. But in fact, in the last 10 years especially, many of us that have been doing this for a long time have had to learn that there are a huge number of non-motor symptoms of Parkinson's disease. Now, they don't make a diagnosis. I'm not going to have somebody come to me and say I'm constipated, and then I'm going to tell them, well, that clearly is Parkinson's disease. Because that would include a lot of people in the population. Many of them sit in public offices and things like that. But given that, we don't use that as a, but it's important because why? If you have less than one bowel movement a day, it increases your chance of getting Parkinson's disease ninefold. Okay? Yeah, without, so this is not something trivial I'm joking about, but unfortunately, as I said, you can't take that as a risk factor because there are many other things that can also cause constipation, right? So, and we'll talk about that Parkinson's at risk in a second. So remember that there are other signs of Parkinson's. 50% of patients with Parkinson's disease have pain, 70% will have a mood disorder. Fatigue is common in probably 100% of patients with Parkinson's disease. Yet, as neurologists, now we try to treat these other things. For many years, we really only recognize the cardinal symptoms. So that's why I wanted to put them up there. And in fact, that shows because when we talk about Parkinson's disease, we talk about tremor dominant, stiffness, slowness dominant, and postural instability dominant, and that's it. We don't talk about fatigue dominant or mood dominant or any of these other things. I'll tell you that there is now good literature that shows that if you treat the mood disorder, the depression in a patient with Parkinson's disease, the response to the motor treatment of Parkinson's disease is much better. Okay? And that's something we didn't recognize. Now, obviously, finally, the brain is a chemical soup, which has serotonin and dopamine and norepinephrine and all these other things that are all linked together, which is why sleep dysfunction in Parkinson's disease is so common. But nobody's really done a huge amount of work on any of this. The other reason, for example, constipation is important is that we know now that gastrointestinal mobility or motility is reduced substantially in patients with Parkinson's disease. And hence, if I give a pill, say I take a pill, it is expected that within 20 minutes, everything has gone through my stomach into the upper small bowel and bang. But in a patient with Parkinson's disease, it is quite possible that because of the slow motility, which is one of the reasons why you may have constipation, that pill is going to sit there maybe for an hour. So when you start now having interaction with food, this becomes important. So the classification of Parkinson's disease is really based on motor symptoms, yet we have a huge number of other symptoms that present. Okay. Parkinson's disease is a huge topic. So I'm giving you just vignettes and giving you little things about how the landscape of this is laid out. We again talked about the anatomy and the basal ganglia and their function, why cells die, environmental and gene exposure, some of the statistics. We talked about the cardinal symptoms, and we'll tie them together towards the end again in a minute. And then the treatment options for Parkinson's disease. So when I said that at the start, we have the treatment home run of Parkinson's disease. This is an important thing. All of you probably in the audience, if you have not, should see the movie Awakenings. which is a story about how levodopa made a difference to patients who were akinetic rigid. And these patients were bedbound with Parkinson's disease. But it wasn't Parkinson's disease, but it was post-encephalitic Parkinsonism. But it doesn't matter. In fact, levodopa had been tried by Berkmeyer and others in Europe for treatment of Parkinson's disease because they discovered it in Europe, this dopamine loss, that black versus loss of all that black, by Ole Hornikevich and Berkmeyer and the group that subsequently got the Nobel Prize for this discovery. And they tried levodopa in those patients, but in a low dose, and in fact published a paper saying that levodopa failed to treat Parkinson's disease. Can you imagine that subsequently Kotzias had not gone ahead and given much higher doses of levodopa? Today we'd be standing saying there's minimal treatment for Parkinson's disease because levodopa was shown to have failed. What was shown in that movie is that the amount of levodopa that was used in terms of what we use today, which is maybe 800, 1200, 1300 milligrams, which is about a gram and a half, what was used in that movie was 25 and 30 grams of levodopa. And it wasn't until that dosage did you see the awakening. And the reason for that is because levodopa is metabolized to dopamine outside here and gets converted so quickly that only about 1% was entering the brain. So you have to give a huge amount to have penetration in the brain. Today we've got another compound that goes along with levodopa that stops that peripheral metabolism and allows levodopa to enter the brain, but still only about 10%. But that made such a huge difference to those patients that in fact it really was an awakening. And because you now have a chemical that is missing in the brain and you replace that chemical, in fact there's no other treatment in neurodegenerative disease or neurological disease across the board that replaces the chemical that's missing. Not myasthenia gravis, not Alzheimer's disease, none of those diseases that we have in neurology are as well linked to a single neurotransmitter that replaces that. Okay, so that's why we say that we hit a home run with levodopa, and the treatment options of levodopa are currently the best options that we have. Then there's surgical treatment. I talked about deep brain stimulation in terms of where we put it. It is an accepted procedure, but it is in highly selected patients that benefit significantly. In fact, those symptoms that I showed you as non-motor, pain, fatigue, constipation, etc., that are not responsive to levodopa because they're not motor symptoms, and remember we talked about dopamine in the motor loop when I showed you that anatomy, those symptoms will not respond to DBS. So if somebody comes and says that, I'm so fatigued and tired no matter what I do, etc., or I'm falling a lot, my balance is poor, my speech is bad, my cognition is not good, and they are not responding to levodopa to treatment of those symptoms, they're not going to respond to DBS either. So selection becomes the most important thing that we do when we put those electrical wires in the brain. So as I said, gait, cognition, speech can worsen, even personality changes can occur after the surgery, and older people don't do well because of that. Okay. So here's the kind of thing that we put in. This is the device, and many of you have seen this is just from the Medtronic website. We don't put two pacemakers anymore. This is an old picture. We just put one which goes onto both sides. And this is the kind of frame that we put on. The patient's awake during the entire procedure, by the way, until the end where we tunnel the wires and put the pacemaker. Until then, you're awake for about 7 hours while the procedure is being done. Okay. Here's the operating room setup. That was the setup that when I moved here from MIT, we cobbled together. Now everything is reduced to a laptop. So all of these big boxes are all gone, but I still use the old picture for nostalgia, I suppose. But the technology is the same, but now in a small box as compared to all those wires which I had plugged in as banana cables. And here's Andy Parent doing the procedure. Again, the patient is awake underneath there, and we put the electrode in. And so how you can record the brain cells? Can you hear the brain cells firing? He's moving the patient's hand, and so let's play that again. See? So that's how we know where we are, because that actually is recording from deep in the brain. We've got an electrode stuck about 6 inches down, and he's moving the arm while I'm sitting at the other side. In the old days when we were still doing this together, now it's all streamlined and he can do it by himself. Let him loose now. Surgeons, you have to really... Anyway, so he moves the arm and you can hear the brain cells going... So we know that we're in the hand area. of this particular region, etc. So when we have patients put their hand out and you hear the tremor, you can hear that in the brain. And you can actually turn it off by putting current right in the brain. So you increase the current and you can stop the tremor, and you can hear the cells stopping firing. So this is how DBS is done. After this procedure is done on both sides, we then tunnel the wires and put the pacemaker in, and the patient goes home in 2 days, and then I do all the programming along with my nurse that's in the clinic, and we reduce the medications and adjust their DBS, etc. About 50% of patients can come off all their pills with this procedure, but there are some side effects, as I talked about very briefly. So medication, levodopa is the best drug out there, and there are lots of other things around that, followed by deep brain surgery in selected number of patients. So we talked about this very briefly. So Parkinson at risk and the dual hit theory. So the reason that this is important is because about 8 years ago, this gentleman by the name of Heiko Brack showed that, in fact, and the reason I show this is that substantia nigra, which is the one that I told you, that black thing, is actually affected late in disease. And what he said was that, go back up. What he said was that the disease doesn't begin here in the substantia nigra, but potentially down here, which is in fact where constipation, smell loss, and other such symptoms might be in terms of the beginning of Parkinson's disease. So he called them the presymptomatic phase. That's assuming that the motor symptoms of Parkinson's disease are the symptoms. And remember what I said, there are so many other symptoms that today we're recognizing could be harbingers, although we don't use them to make a diagnosis. So what we believed as stage 1 Parkinson's disease in the pathology, he has termed, and many people have accepted this in the large scheme of things, is actually stage 3 and 4. So already by that time, many other symptoms have happened. And what are those symptoms? Well, things such as constipation, anxiety disorders, rapid eye movement disorder, or called REM behavior disorder, are some of them. Okay? So smell loss is another one. So 100% of patients with Parkinson's disease will have smell loss. Okay? Constipation is present in almost everyone. Okay? And REM behavior disorder can predate, and here are the numbers. Okay? REM behavior disorder, which I'll tell you what it is in a second, which is acting out your dreams. So in REM sleep, we're supposed to be paralyzed, right? We have random, rapid eye movements. We're dreaming, but we're supposed to be paralyzed. Well, in these patients, they are not paralyzed. So REM behavior disorder patients act out their dreams, and it might sound funny, but it isn't. I've had patients who scream out loud or attack their partner, fall out of bed and thrash around like this and do fairly significant damage. And I'll show you, this is a care partner with the injury from REM behavior disorder. Right? So this is the wife of our patient who was injured because of the patient flinging their arm. Now this is during REM, and one of my colleagues has done a lot of work with respect to that, and I'll show you that in a second. So predating, so anxiety disorders, over 4 years of predating, rapid eye movement disorders about 12 to 15 years before the onset of motor symptoms of Parkinson's disease. So why is this interesting? Well, it's interesting because if you have somebody that has got significant constipation, has lost their smell, has had REM behavior disorder, has a father with Parkinson's disease, is a farmer exposed to insecticides and pesticides, you do the math, right? You're going to say, wait a minute, somebody like this potentially, and they're not uncommon, right? This is actually common. Could be someone that if I had a medication that I could give or some other intervention that I could suggest, should try that first. One of them, for example, is exercise. So there's good data to show that exercising regularly every day, an hour a day, early in your life, that is an investment, just like your RSP might be, potentially, well, not these days, I suppose, but exercise is that kind of an investment. If there is a medication that I could take, and some people say it's coenzyme Q, maybe it's creatine, any of these things that are being sold without evidence, by the way, to a large extent, might be those interventions that you want to do 10 or 12 years ahead of time. Okay? So we talked about constipation, but as I said, the last line is all that's important. There's lots of studies and things that have been done. Constipation may precede Parkinson's disease by at least 10 or 20 years. As I said, that doesn't mean that every patient that's constipated is at risk, but it's something to think about if you have the package together, and that we talked about. The one other thing that's interesting, again, in the last 5 years is the use of ibuprofen. So those patients, those people that use ibuprofen on a regular basis, not aspirin and other non-steroidals, but ibuprofen, have a significant, like smoking, in fact, relative reduction. In fact, smoking and ibuprofen are still not as good as exercise, by the way, on a regular basis before you get the disease. So not after you get the disease in terms of neuroprotection. That data is feeble, but certainly before. It may very well be, and some people have talked about this in this paper, that those that take a lot of ibuprofen are probably also heavy exercisers. Maybe that's why. But it's not the other drugs, it's specifically ibuprofen that reduce the relative risk of Parkinson's disease in the cohorts. This is an interesting finding. Again, if you tie back to that slide of inflammation that I showed you, right, a bunch of things that were on the slide, inflammation was one of them. Maybe ibuprofen is involved in reducing inflammation in the brain. In fact, the NIH is doing some trials with respect to that. The other last thing with respect to this is uric acid, thing that's increased in gout, for example. So this is also a study that's being done, a large-scale study that's being done in the US. So as serum uric acid increases, it seems to be that the hazard ratio, i.e. the chance of getting Parkinson's disease, decreases. So again, if you manipulate uric acid, it might be. So these are all little anchor points that scientists are trying to cling to see, can we do something in terms of neuroprotection? Okay. So then there are lots of other symptoms. We talked about RBD, constipation. I just wanted to review that quickly. Confusion, hallucinations that occur, hypotension, restless leg syndrome in Parkinson's disease. These are all Parkinson's disease. Okay. All of these things are together in the package of Parkinson's disease, mood disorders, cognition, etc., which presents in the classic construct of Parkinson's disease as flexed posture, mashed faces, hypomimia, drooling, reduced ability to write, mood difficulties, difficulty with activities of daily living, arm swing difficulties, fatigue, pain. All of these things make up the spectrum of Parkinson's disease, and in fact, that's why a multidisciplinary approach is often needed, not necessarily multiple different people, but our ability to treat a whole bunch of these things, such as botulinum toxin or chewing gum for drooling, okay? Botulinum toxin, zeomin treatment that we're doing for tremor, rosagiline for freezing of gait. These are all studies that we're doing in London, and I'll show you a couple of them in a second. Okay, in advanced stages, you'll see that a majority of those symptoms go away, the classic ones, and are replaced by swallowing difficulty, falls, gait freezing, dementia, sexual dysfunction, wearing off, and dyskinesia. Unfortunately, the home run that we hit with levodopa didn't last more than 7-10 years. So after you've taken that medication for a length of time, unfortunately, as the cellular degeneration in the brain progresses, the response to the medication doesn't last. Now, I want to eliminate one myth, and that myth is that if you take medication early, it stops working early. That doesn't happen. So convincing data, the drug is not toxic, doesn't worsen Parkinson's disease. Okay? The one symptom that I'll concentrate just for 15 seconds is falls. In fact, freezing of gait and falls that occur in Parkinson's disease is the single most cause of the highest mortality in the elderly. In fact, fall-related morbidity and mortality far outweighs even motor vehicle accidents that occur in the young people. So this is the highest cause of mortality, and in fact, if we can do anything to reduce and prevent falls in performance of activities of daily living, and if you put a patient in a chair and have them do nothing, then of course they're not going to fall, but they won't be able to do anything at all. So our job is also to be able to get them to perform activities of daily living for patients while reducing the fall risk. Okay? And it's not responsive to medications most of the time, which is the problem. What happens is that as disease progresses, we have a very wide therapeutic window for the home run. So you've got a very nice bat and a strong batter. You can hit anywhere and you'll get a home run. Gradually over time, that area reduces such that now you have to tell the batter, only there, if you hit there, when I'm going to get you a home run, nowhere else. Now the ability of the doctor/patient to be able to respond that way reduces, and you start getting fluctuations and dyskinesias, and this is what happens. So here's a patient of mine who has developed dyskinesia, which is this excessive abnormal movements, fluctuations. And these patients have been very kind in allowing us to use their videos for teaching, and we use them extensively throughout. So they all have signed consent for this. And this is dyskinesia that occurs after using medications for a period of time, but in a patient with Parkinson's disease. So control, somebody that's normal will not get this happening if they're taking this drug. So I could take 10 tablets like this and I will not develop dyskinesia. Right? So you can imagine in advanced disease what would happen to somebody like this, where dyskinesia now become disabling to the patient. And Clearly, in this situation, management becomes a very different ball game than early in disease, when response of medication is very nice, linear, patients are happy. It's what we used to call the honeymoon period. We don't call that anymore. We call that the long duration response that occurs in patients, which means that you take the medicine and it's almost as though you're in cruise control and everything's working great. This is freezing of gait. You can imagine how difficult it would be for this lady to perform when gait is so frozen. She's on, which means the drug is working for her. She's dyskinetic and frozen. Those of you that had this symptom will know how difficult this is, and she's unable to walk. You can imagine how high a fall risk this is in terms of Parkinson's disease. Okay. All right, so what are the new frontiers? We've talked about Parkinson's disease in a very rapid bullet train kind of way, talking about the pathology, pathogenesis, and we're going to get to the last few minutes. I know it's hard to talk about Parkinson's disease and the extent of it and finish very quickly. A few more slides, so just bear with me. In terms of what we're going to do in the latest aspects of Parkinson's disease in terms of treatment. So to date, and I've got one slide on each of these things, transplantation, fetal nigral, and I want to debunk some myths, that's why I've got them here. Fetal nigral cells, porcine cells, all of these kinds of cells have not benefited in the large scheme of things. So this is entirely a research protocol still. We're not doing transplantation in anybody. Individual patients might have done well, but most of the time patients have not done well, so transplantation is not being done. Don't go to China or India and have random things put up in the spinal cord. It's happened. I've got patients who've gone all over the place, including children who've had fetal pink fluid things stuck into their spinal fluid. God knows what it is, but and cost $50,000, and it's not been validated. Please don't go ahead and do that. That's wrong. Okay, so transplantation, stem cells, the same thing. You can get stem cells from a variety of different places, but until now, we really have no particular data that shows that it's of benefit. A lot of people are working on it, and it's great scientifically, but has not been therapeutically useful. In fact, there's some data, the development of cancer cells in terms of what you implant is also a risk in animals, in animal models, and hence is something that you've got to be very careful with. Okay? Growth factors and gene therapy, delivery of genes, you can imagine that all of those nuclei that are connected with millions and billions of neurons have to have the gene delivered into every cell, and that's a very difficult task. Currently, gene delivery with GDNF or other growth factors has not worked. Okay? There's also a risk overall of melanoma in patients with Parkinson's disease, and hence there's a mandate for most of us that are doing movement disorders to keep telling patients to make sure that they have their skin checked by their family physician because melanoma is a higher risk in patients with Parkinson's disease. Might be a link to the fact that I told you that brain cells and skin cells have the same ectodermal origin, and it could be related to that. Okay? So the last few slides, I'm going to tell you a little bit about the work that we're doing. I'm leaving the virtual reality part to the end because that we'll talk about at the end, and that's going to be what this was supposed to be about in terms of overall, but you couldn't really tell you for a whole hour about virtual reality. So I gave you hopefully a basis of the complexity of Parkinson's disease. I told you that this is a varying disease. It has all those nuclei that are affected. And today, we don't have a diagnostic test for Parkinson's disease, nor do we have any particular way of following patients with Parkinson's disease. And that's related to the fact that we don't have something called a biomarker, something that you can test in the blood and say, you've got sugar of 12, take 16 units of Lante insulin. We don't have anything like this in Parkinson's disease. In fact, we don't have anything like this in any neurodegenerative disease. It would be wonderful if I could say you've got the 38% Parkinson's disease thing, but we don't have such a value, and that's something is what we call a biomarker, something that you can use for diagnosis maybe, or at least to follow a patient over time. What we have is clinical judgment. So because we have the ability in London to image with magnetic fields that are extremely high, and this particular scanner we use is a 7 Tesla magnet, just to give you a relative sort of look, the magnets that we use in the regular MRI scanner is 1.5 Tesla, 1.5. So this is threefold, a little more than threefold in strength. Or fourfold actually in terms of strength, more than fourfold magnetic field. So we can get really tight resolutions of the regions of the brain. Why is this important? Well, it's important because even though 95% of our brain is made up of water, and that's actually what the signal they use for imaging in an MRI scanner is, it's a water signal, there are lots of compounds underneath, dopamine being one of them, but there are a lot of other compounds underneath that you can measure. But unfortunately, because resolution is not good with the imaging techniques that we've had so far, we've not been able to image them well. The stronger the magnetic field, the bigger the lens, the more I can go in and hone in. So for example, if I have a microscope, I'll be able to see that there are actually lots of bugs floating around my skin. Same thing happens in terms of using a heavy-duty magnetic field. We can zoom in on those deep nuclei, because magnetic field drops, deeper you go. So that's why the 7 Tesla magnet is useful. And we've been able to use that 7 Tesla magnet to image deep structures in the brain. This has never been done by anybody. The substantia nigra has never been imaged with a 7 Tesla magnet on the planet. So this is the first time that this work has been done in our lab at Robarts Research Institute, along with Dr. Rob Bartha. And we now have that ability to do that. It has been done in other, people are beginning to use it in other things as well, but in Parkinson's disease it has never been used. So our job was to evaluate the neurochemical profile in those nuclei, the substantia nigra and the STN, using the motor phenotype differences that we see in patients with Parkinson's disease. So we did that, and here are a couple of pictures, and you can see that these are called spectra, magnetic resonance spectra, that occur on both sides. This is in the subthalamic nucleus, this is in the substantia nigra, and even with that, we're not able to get down to the small little detail. If we had a 25 Tesla magnet, maybe we'll be able to go down and actually image the real small cells of the nigra, but then I'm not sure exactly what that'll do to the hair of patients if we put somebody in that kind of a magnetic field. So 7 Tesla is, but most patients have been able to tolerate a 7 Tesla magnet. And what you can see there is that we get all of these peaks. This is a compound called N-acetyl-aspartate, glutamate, glutamine, creatine, choline, minoxidil. These are all a variety of different peaks. It's kind of like a spectrum from white light going through a prism. You see all of the colors. Well, that's what we're seeing. These compounds can be measured. Why is it important? Because the first one, for example, N-acetyl-aspartate, is a compound that is specifically found in neurons and their projections, axons, not in other parts, not in other cells. So we can actually measure quantitatively, and we can do that, N-acetyl-aspartate. We might be able to start getting an idea as to what it is that happens in the substantia nigra by measuring this particular compound and the others and doing their ratios. So we've done that in 7 patients with tremor dominant, which is predominantly tremor and nothing else. They've got other symptoms as well, but much less. And a group of patients that are predominantly not tremor dominant, those are stiff and slow. And can we see a difference? And in fact, that's what we see. Why is this important? Because clinical data has shown that tremor dominant patients seem to progress slower than those that are stiff and slow and falling a lot earlier. Okay, so we have this 2 groups of patients that we've seen, and in fact what we see is their substantia nigra are different. So the patients that are tremor dominant, that don't progress as fast, have much more, look much more like controls, whereas those that are akinetic rigid dominant are much more likely to have loss of cells in their brain. So this is something that has never been shown before, and we're going to start using this technology to try and follow these patients over time to see whether that change in tremor dominant patients in various regions of the brain can tell us what it is about their progression that is different in terms of pathology and location. So this is something that we're doing in London for the first time. And then the last, of course, is what people have had advertised in terms of virtual reality. Now let me frame this a little bit as to why we started doing this project of virtual reality. I told you how complex Parkinson's disease is, but yet predominantly the difficulty and dysfunction that occurs in patients with Parkinson's disease is ability to perform motor tasks in a contextually driven environment. So I'm standing here with a context. I'm thirsty, hence I open this and I take a drink of water. This is context driven. This is not random. In fact, almost every task that we do, whether it's brushing teeth, going to the bathroom, going to the grocery store, crossing the street, is not random. It's driven as a contextually driven task. In fact, in occupational therapy, this is something that's well known when patients that have had a stroke or hip procedure done, to train them in activities of daily living. So OT departments have small little kitchens where you go and ask them how do you make an omelette or something like this, or make a cup of tea. But these are extremely limited. I need to understand how Parkinson patients, who are actually not weak, so strength training and doing those kinds of things are not necessary for patients with Parkinson's disease, how it is that Parkinson patients fail in that motor control task domain, task space that is abnormal in the basal ganglia that I showed you right at the start. So as I said, those basal ganglia are involved in motor control, and it's that motor control that fails in patients with Parkinson's disease. It's not that they're weak and they can't move their arm up and down at all. That's not what happens. But I don't know how to do that task. Well, we need to train patients in an environment, understand their ability to function in an environment that has context. So serendipity being what it is, in many years ago when I used to do a different kind of workout routine where I used to run on a treadmill, which is exceedingly boring and I would not recommend it to anybody. But while doing this inane treadmill running task, which we also get our rats to do in the lab, I realized that it would be much nicer if I could run and see on a visor as though I'm running at Champs-Élysées in Paris, or in a forest in Guatemala. Wouldn't that be nice? And in fact, if the terrain were to make changes on that treadmill, so I went to MIT, so I like taking things apart. They didn't teach us how to put them back together, but at least we learned how to take them apart. So I took the treadmill apart, which gave me an excuse not to use the treadmill, and bought a visor from Australia, which was cheap online, and came, and the idea was to write software so that I could have a video feed on my visor and connect that to the little board that's in these huge expensive things, which is actually only a $20 controller board in the treadmill that allows you to go up and down and speed up and down. That's it. So the idea was, could I change the terrain as though I'm running up and down hills while I have a picture going through? Proved to be much more difficult than it actually seems. But that led me to contact Mike Kachba, who's a professor of gaming technology at Western, and one thing led to another. We said, wait a minute, this would be phenomenal to try and use as a rehabilitation technique in patients who've got motor disorders. First pilot project. This is an apartment that we built, kind of cool. So here's the up-end view of the entire apartment. This is actually in real space, by the way. We didn't build the apartment, it was 2 feet by 2 feet. It was full size apartment. So we had a huge big hall that was basically empty. Patients put on a visor, and this first iteration, we actually had to have a cable connected to a computer, and we had a grad student, very useful, pushing the carts behind the patient, because otherwise, you'd yank the visor off. So we actually tested navigation in grad students in computer science at the same time as patients with Parkinson's disease. And the idea was that as you navigated through this apartment, and you navigated through the apartment, and I'm not sure if any of you in the audience participated in this, you could see as you turned your head, you saw your television set, and this side was the kitchen, and it was actually a fully functional, mobile, virtual apartment. And what we showed, of course, on the right side, the graphs are obvious. There was a clear difference. Patients with Parkinson's disease were slower, had a difficult time. But what was interesting was this, okay? It wasn't that patients just did things slowly. Patients did them wrong. Let me give you the two scenarios that we had. The first scenario was where we had a line that went from the patient's chest directly from place A to place B. So you started in the living room facing the door, and then you turned around and the line took you to bedroom number 2, because here's bedroom number 1, and here's bedroom number 2, here's a study, there's a toilet, there's a kitchen, living room, etc., all furnished. In a man's sort of way. But as you can see, there's a big television and nothing else. But there were 2 guys in computer science that were obviously writing the software. But anyway, we subsequently have done a better job at furnishing this. But any case, so the idea was that the first set of trials was with this line going from one place to the other. And patients did this not well, but accurately at least. Then intermixed within this task were tasks where what we call a search task was put in, which means that we put the patient in one corner, facing a corner in the bedroom, and said, okay, now go find the kitchen. So you had to turn around and say, okay, and they were all oriented to the patient was oriented to the apartment. It wasn't brand new, and the apartment was the same every time. You're supposed to find the doorway, say, there's the door, there's the closet, there's the window. And you walk through the door, and it was interesting to watch what controls did. So we'd walk out through the door, and the first thing, and let me ask you this question. If you were to walk out into the corridor, and you saw a wall on one side and the long corridor on the other, which side do you think, Nicole, that you would look first? Which side?
Corridor?
No, most patients control, 50%. Most patients look to the wall. You know why? Why? I mean, we didn't anticipate this, but this is exactly what happened, because the first thing you do is, I don't want to go that way. And that means that I'm efficiently going to go that way. You don't know which side immediately. Once you know that the court, because it happens to me all the time when I travel a heck of a lot. I was in 3 different places in the last 5 days. When you get out of the elevator bank, whichever bank it is, because there's 3 elevators here, my room is on the right side in some hotels and on the left side in some hotels. And depending on which elevator I get out of, it could now be on the left in the same building and right. And we have to make this decision all the time, right? Even in your own home, when you get up in the middle of the night, you want to go to the bathroom, you're sleepy, you have to know that the bathroom door's on the left or on the right, depending on, and this can be quite disorienting. But controls repeatedly and consistently looked to the right side, if the wall is on the right side, and as soon as they realized that that's not the way they want to go because there's a wall there, they made the choice. Parkinson's patient didn't do that. There was a flip of a coin. Some looked left, some looked right. Didn't help them to make the decision that if it helped them, that's fine, that this is where I want to go. No, they'd look there and then still make the decision to go this way. So if you look at the path or the trajectory, which is what we did, because everything was tracked with a camera on the visor, was really neat. So the control, start there, boom, out, corridor, end in the kitchen. No problem. Quick. Okay. This is what the Parkinson patient did. And there, back here, around like this, up into that room, oh, that's not it, and go here, out here, back there, etc. Now you can imagine doing that at 2 in the morning, right? Fall risk, we talked about, this is much higher, right? So if I can orient somebody to walk better in this environment, teach them that's not, and this happened consistently, I mean the statistical significance was so huge, and all of these patients drove to the clinic, right? Drove to this, right? So these are all cognitively intact patients who had a Montreal Cognitive Assessment score of 28 out of 30, 27 out of 30 or higher, okay? Because we excluded people that were cognitively impaired. And this is a navigation problem that patients with Parkinson's disease have. Nobody's ever demonstrated this. Paper is in press as we speak now in gait and posture. So we said, okay, well, this is the first step. Now I want to do tasks. So we've just completed the next phase of this second iteration of software.